Funding for Yale Cancer Answers is provided by Smilow Cancer Hospital. Welcome to Yale Cancer Answers with the director of the Yale Cancer Center, Dr. Eric Weiner. Yale Cancer Answers features conversations with oncologists and specialists who are on the forefront of the battle to fight cancer. This week, it's a conversation about radiation oncology with Dr. Peter Glazer. Dr. Glazer is the Robert E. Hunter Professor of Therapeutic Radiology and Professor of Genetics and Chair of the Department of Therapeutic Radiology at the Yale School of Medicine. Here's Dr. Weiner.
Can you just tell us a little bit about you? How is it that you came to become a radiation oncologist?
Yeah, so I'm a physician scientist with an MD and a PhD in genetics. And as you mentioned, my medical specialty is in radiation oncology. And my research focuses on fundamental cancer biology and development of translational research opportunities. So I got started in the field because of a strong clinical interest in oncology and in taking care of cancer patients. And that was coupled with a growing research interest in the field of DNA repair, which is how cells fix their DNA. And that's an important topic in the field of radiation oncology.
And can you just tell us a little bit about radiation as a treatment, both in terms of how it's delivered, or I should say the different ways in which it can be delivered, and then we'll explore some other aspects of radiation.
Sure. So, radiation oncology is the medical specialty that uses focused X-rays to treat cancer because of their ability to kill cancer cells. And early medical applications of radiation were based on radioactive materials like radium that were discovered by Marie Curie, because early on it was found that radiation causes tumors to shrink. Later on, other isotopes like cobalt, iridium, and others were identified and developed. And some are used for a type of treatment called brachytherapy, which involves placement of radioactive sources in close proximity to a tumor, as is frequently done for cancers of the gynecologic tract in women.
So a device is actually put in and it gives off radiation while it sits essentially near or within somebody.
That's right. It dwells in the next to the tumor. It's put in a surgical procedure, and then it's removed after a specified time. And then in some other approaches, isotopes are injected systemically for special applications, usually linked to a carrier like an antibody. So, when X-rays were first developed, it was known that they could be generated by cathode ray tubes, but that was low energy and had drawbacks. So after World War II, a major advance was the development of technology to accelerate electrons at high voltage into a medical target to generate high-energy X-rays or photons. And that was the birth of the linear accelerator, or LINAC. And this allowed for treatment of deep-seated tumors in the body with sparing of superficial tissues.
And it seems to me that it was the case many years ago that radiation oncologists would take an X-ray, just a standard X-ray that might show, for example, in the chest, a lung cancer. And in what now seems like a pretty crude manner, they would just draw around that tumor and then aim the beam at the tumor. Is that basically right?
Yeah. Early on, the treatment machines were limited in their ability to move and to deliver shaped beams. So most of the treatments were from the front or the back of the patient in a simple way. And so we were guided by what we kind of referred to as two-dimensional imaging, which is those plain film X-rays. But, one of the major advances in the field has been the use of advanced imaging like CT scans, MRI scans, or now even PET scanning to create three-dimensional images of the tumor target. And that's coupled with many technological advances in the linear accelerators that allow the delivery of very complex beam arrangements that really shape the dose distribution in a three-dimensional manner.
And my sense is that by using those three-dimensional images like CT scans and with the changes in some of your equipment that delivers radiation, the two things have happened. The treatment is far more effective, and at the same time, you can spare patients a lot of the side effects that used to be pretty commonplace.
That's right, because now we can shape the dose distribution a lot more conformally to the tumor itself and substantially reduce the dose to surrounding tissues. So that's allowed us to deliver the treatments much more safely with less side effect. And in some cases, we can give a higher dose each day and reduce the number of days of treatment. That's also a benefit to patients.
Now, before we get into some additional advances, maybe you could just comment on some of the myths that people still carry around about radiation, in not such a different way than with chemotherapy. There are a lot of patients who come see us and have preconceived notions about what these treatments are like and will come in saying, well, I'm never doing that because my, great aunt received that and had some terrible problem. What are the specific misunderstandings about radiation?
Well, I think that one is what we were alluding to before is, historically, some people may remember that people treated with sort of the older-fashioned ways of giving radiation developed skin burns that, were very challenging to treat and to heal. But, the advances that we just talked about in delivery of radiation more deeply into the body and sparing the skin with shape beams has allowed us to substantially avoid the skin damage and also side effects to other tissues. So not saying that doesn't sometimes happen. There can be some side effects to the skin, but it's much, much less than it used to be.
And the skin, and for that matter, other organs too.
Yeah. So there is some effect of radiation as it passes through healthy tissue, and sometimes that can lead to some fatigue and temporary loss of energy. Sometimes if patients are treated in the area of the head and neck, they may develop dry mouth, or if they're treated in the GI tract, they may have some symptoms associated with that, but usually these symptoms fade over time.
What are some of the most common uses of radiation?
About 60% of all cancer patients are treated with radiation, and many different types of tumors are treated. One very common treatment is for cancers of the head and neck, where radiation is considered a curative treatment, often in combination with chemotherapy. We do a lot of radiation treatments for breast cancer, prostate cancer, brain tumors, and tumors of the GI tract. I mentioned gynecologic malignancies, where radiation is very effective and routinely achieves curative effect in many of those scenarios.
And in some cases, this is a substitute for surgery, and in some cases, it's done in conjunction with surgery.
Yeah, that's right. Radiation is particularly effective for localized disease and can be an alternative to surgery in some cases, either because the individual is not medically able to undergo a operation, or because the morbidity or side effects of getting radiation may actually be more favorable than a surgical intervention.
Not so many years ago, when someone would have cancer that unfortunately would spread to their brain, they very commonly would get radiation to the entire brain, to the whole head, essentially. And increasingly over the years, it seems that that's not the case. And treatments that are referred to as either stereotactic radiosurgery or gamma knife have been used and have been very effective. Can you tell us a little bit about those treatments?
Yes. So you're absolutely right that, years ago, for metastases in the brain, treatment would be given to what we call the whole brain, which is basically the upper part of the head through and through. But the advances that I was alluding to in terms of the technology, the treatment machines, and also specialized devices like the Gamma Knife allows very focused treatment of individual metastatic lesions with really exquisite precision that allow a good deal of sparing of the surrounding healthy brain. So now it's pretty much standard of care to treat the metastatic lesions fairly aggressively, but with highly focused treatment. And the Gamma Knife actually is one of the best devices to do that for brain lesions because of its high precision.
I mean, this has really transformed in many ways the treatment of cancer that has spread to the brain and has allowed people to live longer and at the same time live much better.
Yeah, that's right. And it's become especially important as systemic therapies have improved. So now we are, like I said, taking a more aggressive approach to trying to treat lesions in the brain when the systemic disease can be controlled by other approaches.
It seems that there are even newer approaches, and you have a new machine that gives guided radiation. And maybe you can tell us a little bit about that and what kind of guidance is used.
Yeah, so this is along the lines of what we call image-guided therapy, in which the linear accelerators have an onboard imaging device to help us evaluate and modify the treatment, at the time the patient is in the machine, and in some cases almost in real time. This approach started with CT scan and MR scan included in Linacs, but this new biologically guided therapy incorporates a PET scanner or PET imager in the device. So a PET scanner images positron emissions from radioactive tracers that accumulate in the tumor when certain compounds are given to the patient ahead of time. And that allows us to account for the localization of the tumor and also its motion within the patient, and in some cases, depending on the tracer we use, on its biological properties. And then we can modify the treatment beamlets in real time based on the positron emission pattern.
How much experience have you had with this so far?
We've had it going for about a year, and actually I think we have one of the largest experiences in the country with this. So we're getting more familiar with how to best incorporate this technology into our treatment of patients.
So it's really taking the treatment even a step further than you would with just a CT scan alone, because with the PET part of that imaging, you can tell much more about what's going on in the tumor.
Yeah, it has a new dimension. I mean, right now it's primarily valuable for accounting for motion, especially lesions in the lung where you have breathing, the breathing cycle that causes motion. But we think that down the road we will have many other applications of the technology.
Well, this is great. We're going to take a break for just a minute, and when we come back, we're going to talk a little more about how radiation works, and then we're going to get into some of the research you've done related to that.
Support for Yale Cancer Answers comes from Smilow Cancer Hospital, where all patients have access to cutting-edge clinical trials at several convenient locations throughout the region. To learn more, visit smilowcancerhospital.org. The American Cancer Society estimates that nearly 150,000 people in the U.S. will be diagnosed with colorectal cancer this year alone. When detected early, colorectal cancer is easily treated and highly curable, and men and women over the age of 45 should have regular colonoscopies to screen for the disease. Patients with colorectal cancer have more hope than ever before thanks to increased access to advanced therapies and specialized care. Clinical trials are currently underway at federally designated comprehensive cancer centers, such as Yale Cancer Center and at Smilow Cancer Hospital, to test innovative new treatments for colorectal cancer. Tumor gene analysis has helped improve management of colorectal cancer by identifying the patients most likely to benefit from chemotherapy and newer targeted agents, resulting in more patient-specific treatment. More information is available at yalecancercenter.org. You're listening to Connecticut Public Radio.
Good evening again. This is Eric Weiner with Yale Cancer Answers, and I'm here tonight with my guest, Dr. Peter Glazer, who is a professor of therapeutic radiology and a professor of genetics here at Yale School of Medicine and chair of therapeutic radiology. Can you tell us a little bit about how it is that radiation on a cellular level kills cancer cells? What does it do that makes them die?
So radiation that we use clinically to treat cancer is sometimes classified as ionizing radiation to differentiate it from other forms of radiation, including photons, which is visible light. And what that means is that the radiation, X-ray radiation, goes into cancer cells and causes ionization of the molecules inside the cell. And that leads to a lot of chemical reactions that damage the DNA. So fundamentally, radiation causes DNA damage in cancer cells. And if we can provide sufficient damage, the cells cannot fix themselves well enough to recover. And that leads to destruction of the tumor and tumor regression. And
the DNA is essentially the brain of the cancer cell.
Yeah, well, DNA, like in all cells, has the blueprint for how a cell functions. And, DNA leads to the production of downstream molecules like RNA and proteins. So if you get the DNA, then you basically block all of cellular functions and the ability of the cell to survive.
Now, one of the things that one hears as a doctor from patients is the question, well, doesn't radiation cause cancer? And I think people are often thinking about the fact that, repeated imaging studies are associated with a very small increased risk in cancer in certain circumstances. Is that a question that all of you get asked a fair amount?
Yeah, yes, we sometimes talk about that with patients. I think that it is known that there is a link between radiation exposure and developing malignancies. I think this is one of the key reasons that we've worked so hard to develop technologies that focus the radiation intensively on the tumor and work to spare the healthy tissue as much as we can. And we've studied this a lot in the field, and the risk of secondary malignancies is not zero, but it's very low, especially for most adult patients. We worry a little bit more about children, which is one of the reasons that we spend a lot of time in developing treatment approaches for children that are very highly focused. And one of the more recent developments along those lines is the use of proton beam therapy, which is especially valuable for treating children.
And there's going to be a proton beam facility in Connecticut in the not distant future that we've been involved with.
Yeah, that's right. So protons are a type of ionizing radiation, but instead of X-rays, they use protons, which are a subatomic particle, which a machine called a cyclotron will accelerate. And the protons also enter into the tissue, but they have a special property because they're a particle with mass that they enter tissue and they stop suddenly to deposit their dose. And that lets us tailor the delivery of the ionizing radiation even better. And we think that it has some advantages. So, but developing proton beam facilities is not a simple endeavor. It's much more expensive and involved than installing a regular LINAC. And so there are not many in the country, and there is not one in Connecticut right now, but Yale New Haven Health System and Hartford Healthcare have partnered, and we recently did the groundbreaking to advance a new proton beam facility in the center of the state that'll be a resource for all of the people in the region.
And the price tag for these kinds of facilities is in the tens of millions of dollars.
Yeah, that's right. This one is somewhere in the range of 70 million all in with all the construction and equipment. So that's correct.
Can you talk about some of your research? And I know some of the recent research has related to the treatment of what is often thought of as inherited breast cancer and other cancers, that is, cancers that arise in the setting of BRCA mutations. But I know that your research career stretches pretty far back. And what are some of the things you've worked on over the years? And then maybe we can talk more about BRCA.
Well, so yes, I've been interested in how DNA repair pathways can influence the development of cancer and how they can be exploited for treatment. And you mentioned the BRCA1 and BRCA2 genes, which are linked to a large extent to breast and ovarian cancers. And they defects in those genes lead to a deficiency in a pathway of DNA repair called homologous recombination. We recently discovered that some other genes that are seen mutated in cancers that are linked to abnormal metabolism also cause a defect in the same DNA repair pathway. And we found unexpectedly that they can be exploited with molecularly targeted agents that exploit related DNA repair pathways. And similar to the situation with BRCA1 and BRCA2, these genes include genes with the names IDH1 and 2, SDH and FH, and they're linked to brain tumors, sarcomas, kidney cancers, and others. So some of the strategy that we and others have worked on, you can think of it like a traffic pattern. Since you and I live in southern Connecticut, if there's a big crash on I-95 and you can't get where you're going, you might think of going to the Merritt Parkway, but we're using an agent that blocks the Merritt Parkway, so then you have nowhere to go. And so we're taking that kind of approach for these genetically linked cancers.
And this is by developing drugs?
Yeah, drugs that target other DNA repair pathways. So there's a well-known class of drugs called PARP inhibitors. We did not develop them, but we're trying to find new uses for them. Another thing that we did was we found that agents that inhibit angiogenesis, which means the development of new blood vessels, these can lead to reduced oxygen in tumors, a situation known as hypoxia. And that, we found, causes decreased DNA repair. And we can then exploit that situation with some of the agents I just talked about.
And is there a role for using radiation in combination with some of these therapies?
Yes, for sure. So some of these DNA repair inhibitors like PARP inhibitors and others that are in clinical development, there's a number of targeted agents that we and others are working on, inhibit repair pathways that are important to how the cancer cell tries to fix the type of DNA damage the radiation causes.
And if I can just explore one other combination that's been talked about recently. So immunotherapy, of course, has become the treatment of the past decade. It's used in well over a dozen different tumor types and can be highly effective. But there's some suggestion that radiation could also augment the effect of immunotherapy.
Yes, I think there's a lot of intense study, both basic science and in the clinic, on how to best combine radiation and immunotherapy. Radiation can elicit an inflamed response in tumors that synergizes with the type of immune response that these immune checkpoint inhibitors will provoke. It is also thought that radiation can cause the release of tumor antigens and sort of create an in situ tumor vaccine, if you will. So, in general, it's thought that radiation can enhance the effectiveness of tumor immune therapy, and vice versa, that immune therapy or immune response will enhance the effect of radiation.
Have you seen a change in the type of medical student who goes into radiation oncology today versus 20 or 30 years ago? It would seem to me that a lot of these people must be people who are interested in physics and very interested in science and perhaps interested in pursuing careers in research.
Yes, I think it's always been a research-friendly specialty because there's a lot of basic science and cellular biology to explore, as well as the physics and the more technological aspects. I think that, years ago, it was felt, well, maybe people who had a little bit more proclivity for physics might go into the field. But actually, I think the field now attracts people that like the advanced technology that we can bring to bear, the image guidance, the treatment planning that, is very computerized and visual. And so I think it's expanded the reach of people that are interested in the field. And the other thing is, I think people have come to know that we're a very patient-oriented specialty. Just like your specialty medical oncology, we're very patient-facing, and we have longitudinal relationships with our patients, and I think that attracts the medical students as well.
Longitudinal relationships with your patients and of course, close relationships with your colleagues, since in the care of patients with cancer, we all work together, since it takes far more than any one discipline. And as we wrap up, can you speculate about where radiation oncology is going over the course of the next 10 or 20 years? What should we be looking for?
Well, I think that we're going to see a greater ability to achieve real-time adjustments in the treatment using some of these onboard imaging technologies. And as the software and hardware improves, and we can incorporate things like artificial intelligence to identify the tumor targets, track how they move, and adjust radiation treatments. That's going to allow even more precise and tailored radiation therapy for patients. I think also we're going to see more individualized patient treatments based on clinical and genetic characteristics. And like we were alluding to before, I see the next 5 or 10 years that we will be able to deploy new targeted biological agents that sensitize tumors to radiation without sensitizing healthy tissues. And, for example, we're working in the lab to develop a class of peptide drug conjugates that does just that. And the preclinical models look encouraging, so hopefully that will eventually make its way to the clinic.
And, not to set up a competition with surgery, but do you think these changes will lead to fewer surgical procedures and more radiation?
Well, I think it may change the balance for certain tumors. I think I've seen that the pendulum has swung back and forth for different types of tumors where, radiation approaches are more favored, and then surgical. It really depends. I mean, the surgeons have been very good to advance their technology to robotic surgeries and minimally invasive surgeries. So I think it's all to the good for the patients, and we'll just have more choices for figuring out the best treatments.
Dr. Peter Glazer is the Robert E. Hunter Professor of Therapeutic Radiology and Professor of Genetics and Chair of the Department of Therapeutic Radiology at the Yale School of Medicine. If you have questions, the address is canceranswers@yale.edu, and past editions of the program are available in audio and written form at yalecancercenter.org. We hope you'll join us next time to learn more about the fight against cancer. Funding for Yale Cancer Answers is provided by Smilow Cancer Hospital.